Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Hi, everybody. Thanks for tuning in for Direct Connection. Our focus tonight is the growing concern about the Ebola virus and whether Maryland is ready to deal with this possible threat. Joining us tonight is State Health Secretary Dr. Joshua Sharfstein. Doctor, thank you for being with us.
Thanks for having me.
First things first, do we have any possible cases in Maryland that you've heard of at all?
We don't have any cases that we know of in Maryland right now. You know that it's standard practice for patients to be evaluated and for hospitals and other clinics to triage them, and sometimes they may answer yes to one of the questions, but when we look further, we've not had any cases.
You know, the scary thing, reading the news reports, watching the coverage on this is, first off, the nature of the disease itself is pretty scary. But the second thing is the idea that we've had a number of healthcare workers, professionals, who have been infected despite apparently following the rules. They were wearing the proper gloves and gowns and goggles and so forth. In the Dallas case, in Spain and in Liberia, what do you make of that? Well,
with this particular virus, which is obviously very lethal, and if the patient is very sick, is quite contagious for someone taking care of them, there is literally no room for error. And if you look at you know, our rates of hand washing in the U.S. hospitals, they're not always 100%. When it comes to Ebola, there really is no room for error. And one of the things that we need to do is support our healthcare workers 100%. They're on the front lines at the health department. We are doing regular calls with all the infection control people and other healthcare workers in the state, get them information and other support so that they're prepared. I'll tell you that Doctors Without Borders is probably the organization with the most experience taking care of Ebola patients. And I think in decades of working in Ebola, my understanding, they've had like one case of someone getting sick. And they have a very, very specific protocol for how you put on the equipment and how you take it off. And they actually assign someone whose job it is to tell the people exactly what to put on and what to take off, even if they've done it 1,000 times before.
It sounds like that's going to become the standard here. Somebody called it the buddy system, where you have an observer. Same thing, no matter how good you are at it or how senior you are at the hospital, there's somebody watching you do it in just the right order. Because I guess the idea is that you consider that whole outfit to be contaminated.
That's right, and it's not just taking it off, but you have to take it on and off in exactly the right way, in the right order. You have to be washing your hands along the way, and even something as harmless as scratching your nose can lead to infection. So it requires really the next level, 100% guarantee. And I think that what this very unfortunate transmission in Dallas teaches is that everyone has to be ready to do that, and we really have to support healthcare workers.
How does scratching your nose communicate that virus? I mean, I had understood it to be something that you needed bodily fluids, it was a little like the transmission of AIDS. Maybe, is it more readily transmitted than AIDS, but obviously less readily than the standard flu?
That's exactly right. So it's a contact transmission, which means that the virus itself can be picked up and can be transmitted. It's kind of like certain colds can be transmitted that way. And in this case, it's probably from either fluids that actually get on the healthcare worker, on their gloves or on their gown, and we know that for patients who are really sick, it can even be in their sweat. That's really important to remember. We're talking about people who are very, very sick. We're not talking about people who are going to be, sitting on a bus or presenting a risk to the general public. But in that setting, in the intensive care unit, when someone is that sick, they're actually shedding quite a lot of virus.
I really sympathize with and appreciate the nurses and other healthcare professionals that would walk into the isolation room, no matter how many gowns they had on, when somebody was in the latter stages of this disease with the virus, everywhere.
Well, our healthcare workers are heroes, and they do that in many different cases every day. We have we have bacteria that are resistant to all sorts of antibiotics in our hospitals. We have tuberculosis. There are a bunch of threats, and it's the equivalent of a firefighter who's willing to do their job to protect the public. And I think it's absolutely critical, and we're doing everything we can to support the frontline healthcare workers. Lots
of phone calls for you. Let's get to the first one in Delaware. This is Al. Al, thank you for calling. Go ahead.
Yeah, my question evolves around this expediting, people here to this country from these African countries. Why didn't they stop flights? And my other part is, we know that this virus can be airborne in humid, spittle, when people are sneezing or coughing. This is a nightmare, and I think that, especially in the Beltway area, this needs to be dealt with by shutting down these people coming in here from Africa.
Al, thanks very much. How do you feel about that?
Well, travel restrictions have been part of the response to Ebola from the beginning. Right now, it's really concentrated in the 3 countries of Guinea, Sierra Leone, and Liberia. And they've started now screening passengers from those countries who are arriving at the most common airports in the United States. I think that those types of restrictions have to be reviewed, and it may be that there are going to be some changes to those protocols, but what you don't want to do is make things worse. You don't want to necessarily make people, desperate or hiding where they're from. It's better if people you're able to identify any risk so that it can be quarantined and dealt with.
The laws behind medical quarantine are pretty interesting. It's a state-by-state thing, and states treat it differently. I saw that the governor of Connecticut maybe issued an order that would give his health people the authority to quarantine someone, and if there was a case, and quarantine then the people who were connected to that case. And how's it work in Maryland?
Sure. We have issued an order. We did that also with MERS, the Middle Eastern Respiratory Syndrome, and SARS back then, which basically allows hospitals to hold patients until we have a chance to consult with them. So if somebody comes in and is high risk, they can be evaluated and we can make a decision together. If someone actually needs to be quarantined, then we have the authority to do that also. And of course, we have all those orders drawn up, so we can use them if we need to. But at this, this is part of our preparedness, not only for this, but for the Middle Eastern Respiratory Syndrome and other emerging infections.
Baltimore County, this is Carol. Carol, thank you for calling. Go ahead.
Hi.
Hi.
One of my questions is, why are they quarantining the animals?
Anything else?
Yes.
Okay.
Why can mosquitoes not carry it?
Good question. Thank you so much.
So I'm not so much an expert in the biology of Ebola. Actually, tomorrow I'm going to be at a forum at the Johns Hopkins Bloomberg School of Public Health where they're going to bring a bunch of experts to talk about the virus. My understanding is that the exact pathways in animals are not known. I think when it comes to pets, actually the CDC put out a Q&A today on pets that basically said it's very unlikely that a pet is going to get Ebola.
Yeah, the problem with this situation at the moment is that very unlikely doesn't quite go far enough.
Yeah, well, it's sort of, when I'm a pediatrician and I would see families in the emergency department, and a question would be, could it be that my child has meningitis? And what you have to say is, can't say 100% for sure, but here are all the reasons why we're pretty comfortable. You're taking your child home and see whether the parent can understand that. And of course, if there's a problem, you give us a call and you come back. So it's very hard to be absolute, and that can be a little, maddening in this kind of situation where there's so much anxiety. But the truth is, what you don't know, you'd rather have somebody say, we're not sure. I think it's very unlikely that a pet would get it, but I think they want to just rather be safe than sorry.
What I gather from reading the news, watching the coverage of this, is that there's a pretty high degree of confidence that we're not going to have a significant self-perpetuating outbreak of Ebola in the United States, but that until the situation in West Africa is resolved, there's this continuing feeder system for new cases.
Well, what's going on in Africa is a public health catastrophe and a human tragedy. I mean, these 3 countries right now are dealing with a scale of disease that is really hard for us to contemplate in the United States. In some places, they basically have no staff to go to the hospital. And we have to help Africa. We have to help these countries deal with the outbreak that's there. And only by doing that are we going to eliminate the risk to the United States.
Chris in Baltimore County. Chris, thanks for the call. Go ahead.
Yes, thank you. Actually, I have not so much a suggestion, but why isn't it happening this way? I'm concerned that if a patient comes into an emergency room or any hospital situation, or even for that matter, a primary care situation, and exposes the public to, or possibly exposes the public to, high-level risks of contracting the disease, why isn't there a mobile unit that can actually go out and respond, perhaps have people on a list? I mean, if you've traveled from these high-risk countries, be on a list, and if you call the mobile unit and you're on the list, they respond to you, as opposed to having these patients come out and actually come in contact with people that are unprotected. I mean, has that been a consideration, or why is that not feasible?
Great question. Thank you very much. I mean, so...
Yeah, well, to clarify one thing that came up earlier, Ebola is not transmitted through the air. So influenza is. It's very important for everybody who's listening and worried about infectious disease to go out and get their flu vaccine. Because influenza, you can just be in the vicinity of someone and you can catch it. Ebola really requires contact with the fluid that has it. And so that makes it actually less transmissible than influenza.
Play devil's advocate. If it's present in someone's sweat, and you could see something getting aerosolized or somehow getting into the air, landing on somebody, and they scratch their nose or whatever.
Again, it requires, we're talking about people who are very critically ill at that point, that it's getting into the sweat. Right. So it's not, transmitted through casual contact for people who are basically okay. So, if you're sitting next to someone and they're basically okay, the risk is incredibly small. But in this intensive care unit setting, it's a different situation and requires a different level. Yeah. I certainly understand the anxiety. The challenge is that people show up in the emergency room. Right. It's very hard to have a list and have people only know that they should call a number when they will show up, or they may show up in different places. There's no alternative for everyone being prepared. But I think with greater knowledge, what happens is somebody comes in, and I have a friend who went to the doctor yesterday. The first thing they did was say, have you been to West Africa recently? And if he had said yes, he would have gone right into his own room, and he wouldn't have posed any risk to anybody else there. So I think it's really important for everyone to maintain their vigilance, even as we're thinking of all these different ways to help.
What would be the proper response? Say somebody shows up at the Minute Clinic somewhere with flu-like symptoms, and they have been to West Africa. Right. What do you want to happen at that point as the health secretary?
Oh, I'd want them to be identified right away, and they go right into their own room. And then you would call us right away.
And then that interesting idea of a specialized mobile unit that shows up. I mean, would they call 911 and the fire department responds, or how do you then get that person, if it turns out to be an actual case, into isolation somewhere? So
the person would be in isolation right there. You don't need a separate air supply, so they'd be there. They would call the ambulance system, and they would explain over the phone that they've got somebody who they're worried about. Our ambulance system has been training and drilling for this exact scenario. Having one ambulance for the state of Maryland that can take care of Ebola patients is not going to be a good idea. It's a big state. But we do have units that can do this, and we would send someone out, and they would be taken to a hospital where everybody, they go right into a room.
Let's take another call. Carroll County. This is Benjamin. Benjamin, thanks for calling. Go ahead.
Okay, so my question was, how does Ebola spread, and how come the nurse who was helping the victim managed to
Benjamin, we get the drift. Thank you very much for the phone call.
Sure. So what we know about Ebola is that it's spreads through direct contact with bodily fluids. And the amount of virus in the bodily fluids goes up as the person gets sicker and sicker. So the highest risk is going to be in those critically ill patients in the intensive care unit. And that's where the room for error in terms of putting on and taking off protective equipment is really zero. And there are documented cases of healthcare workers who make small mistakes in the way they put on or take off their equipment. They need support so that they don't make those mistakes. And we have to give them as much support as possible, including not just the buddy system, but somebody else in the room observing and giving directions on exactly what to do and how to do it to keep them as safe as possible.
Baltimore City, this is Greg. Greg disappeared for a second. We'll wait a second on the next phone call there. I'm going to come back to the screening a little bit that you mentioned, which starts up this week at Dulles. I think they're doing it now at JFK. Yep. And Dulles does have a direct flight from West Africa. It's not one of the 3 countries. And I think they're just taking somebody's temperature. I mean, I guess if somebody's got a fever, you'd want to know about it, but it's not really going to be foolproof.
I think they're doing more than that. That's my understanding. I think they're talking to them about their potential risk. I think they're educating them about what to look for in case there's a problem. So I think there's a whole range of steps that's being done. The CDC is overseeing that.
Okay, let's try Sussex County. This is Mike. Mike, thanks for the call. Go ahead.
Yeah, my concern is not the capability of the United States handling this problem. I'm very confident in our health organizations. How are we going to handle like people going into Mexico and South America and all these islands that a lot of Americans vacation to? Are they going to be able to stop this the spread of Ebola?
Yeah, good question. Thank you very much.
Well, fortunately, Ebola is really not present in any of those places right now, so it'd be perfectly safe to go there. Certainly, if there were to be cases there, then there'd have to be a public health response. But at this point,
but it was an interesting point that it would be easier for the disease to establish a foothold in another third world or second world country than it would here in Baltimore, Washington corridor.
That's true, but having said that, when the cases come in one at a time like this, it's still possible and probable even that they would be shut down. For many years, every Ebola outbreak was ended through basic public health measures. This was a bit of a perfect storm. It happened in a very remote area at the border of several countries, and by the time they really figured out how bad it was very hard to contain. Having a case come over, like even Nigeria had cases, they were able to shut it down. So I think I don't think there's a huge risk that that would happen in the short term.
Still, it's an interesting point that this might be a good year to get a flu shot, because when flu season ramps up and you have a lot of people showing up at the hospital with flu-like symptoms, you really don't want to be bothering showing up.
It's never a good idea to go to the hospital if you can avoid it. So I think a flu shot, I got mine this morning, is a good idea.
Brenda in Washington, D.C. Brenda, thanks for the call. Go ahead.
Yes, I have a couple of questions to
ask.
My daughter is going to have a series of surgeries in the near future, and I wondered if it would be wise for me to advise her to delay those surgeries because of this Ebola situation. And my second question is, you have a lot of people who may not leave an African country and come directly to the United States. They may go to Germany first and then come over. So what are the airports doing to determine if a person has come through a second country but really originated from a West African country?
Brenda, very good. We'll get you an answer on the air. Thank you for the call. Good luck to your daughter.
Sure. So in order, I would say if it's a patient getting seen in Maryland, there's absolutely no reason to delay surgery because of the potential issue of Ebola. If, in fact, we get a case in Maryland, that person's going to be pretty well isolated and not pose any risk to the other patients. As far as the airplanes go, my understanding is that the way passengers are tracked, it's through their entire itinerary. And so that somebody who transfers planes in Germany is going to be identified here.
Cecil County, this is Larry. Larry, thanks for the call. Go ahead.
Wow, very good show and very interesting.
Thank you, sir.
I was interested to know how they disinfect and how they keep the planes safe from actually all viruses, and is there, what would be the special needs maybe as far as chemicals and such when they disinfect the planes? That was number one. And then two, about the virus maybe reinventing itself and maybe being able to adapt to whatever we do. How much emphasis are we doing as far as trying to keep up with it?
Larry, thanks very much. A lot of fear that the virus mutates and becomes more easily spread.
Right. Well, there are instructions on how to decontaminate, whether it's the apartment in Dallas or any other place. There's very specific instructions that are online about how that can be done. There's obviously, if there's no risk to a particular area, you don't have to decontaminate it. But if there is a risk, there are very clear things that can kill the virus, and it's not clear that it really survives that long out by itself anyway. When it comes to the virus, I'll take both sides of that question. So yes, viruses mutate. It's unlikely they do things that are radically different, but you've always got to be vigilant. And the bigger point here is that the need for science and scientific investigation is incredibly important. It's our knowledge about the virus that can protect us. It's our knowledge about how to protect ourselves and how to protect healthcare workers that's critical. We need to use that knowledge to devise treatments and vaccines for Ebola. We need to not only track its progress, but we need to beat it. And I think it's critically important that the FDA, where I used to work, and companies that are developing products work very quickly with the NIH to identify promising treatments and to test them. It may be that we're going to need a vaccine to control things in Africa, and there's really no time like the present to get that moving.
Anne Arundel County, this is Bill. Bill, thank you for calling. Go ahead.
Yes, I appreciate the Secretary's time, especially as we live here in the Washington area and get the pleasure of such a professional. My question relates to a comment that the Secretary made about the fact that Maryland certainly would have to have more than one ambulance service if there was a minute clinic event or that type of event. In some reasonable range, does the Secretary have any idea how many in the state of Maryland are available to make a response like that?
How many what,
10?
sir?
How many ambulances or special equipped vehicles would be there to help in the event you had a minute clinic type call with someone who appeared to be an Ebola candidate?
Got it. Thank you, sir. There are no special ambulances, are there?
No. In fact, regular ambulances have the capacity to handle patients with Ebola, just like they do other infectious diseases. And the staff have gotten extra training, and the emergency management system, which is led by Rick Alcorta, has been working on training and information for everyone in the ambulance world for several months now, ever since this started in Africa.
I'm interested in the quarantine stuff, and not to pick on Minute Clinic, but it's an easy phrase, but if somebody walked in and I'm working the front desk and I guess I would need to be quarantined for some period of time, voluntarily, or in the case of, we had this NBC News crew that apparently broke quarantine after coming back from Africa. You're the public health expert, so you know more about quarantining people, but how refined an art is that?
Sure. So a couple things. Just to your analogy, it depends on how that patient was handled. But let's just assume after investigation we thought that there might have been an exposure, and it's necessary for somebody to watch themselves for 21 days, which is the incubation period.
So that's different from being quarantined for 21 days?
Well, it would depend a bit. I think we have terrific infectious disease experts at the health department. We would consult with CDC. We would talk to you, understand the level of your exposure and what would need to happen. So let's say we decided that we didn't want you to be around other people for 21 days. We're just going to watch you. Probably what would happen is you would just be going home for 21 days, and we'd check on you. As long as you're doing that voluntarily, there's no need to do any legal gymnastics. Having said that, if people aren't doing the things that are necessary to protect themselves, we do have the authority, and we're ready to do what's necessary to protect the public.
We have a full bank of phone calls here that we're not going to get to, but this would be a good place to remind everybody what we talked about at the top of the show with all the coverage about Ebola. Nobody in Maryland has it.
That's correct, and that we are all working together, the healthcare system, ambulances, the public health department, to protect Maryland in every way possible.
Very good. Dr. Joshua Sharfstein is Secretary of the Department of Health and Mental Hygiene. Thanks for making time for us.
Thanks for having me.
And thank you for joining us for Direct Connection. Join us Thursday at this time for Your Money and Business. We will look at the ins and outs of reverse mortgages. That's Thursday at 7:30 here on MPT. Now, for all of us at MPT, I'm Jeff Salkin. Thanks for watching Direct Connection, and have a good night.
This program was made by MPT to serve all of our diverse communities.